Hello and welcome to Radcliffe Cardiology's webinar in association with Cardiac Failure Review. I'm Harriet Seeger, the online editor for Radcliffe Cardiology, and I'm delighted to be joined today by Professor Andrew Coates, Academic Vice President of the Monash Warwick University Alliance, which is a strategic partnership between Monash University in Australia and the University of Warwick. Today, Professor Coates is going to be talking to us about the management of heart failure with preserved ejection fraction. And as well as reviewing the clinical management, Professor Coates will be questioning the scarcity of clinical trial evidence for high ejection fraction heart failure and discussing why it's a problem of our own making. Just to mention also that you'll have the opportunity to ask Professor Coates questions via the text box on your screen throughout the course of the webinar, and she'll answer as many as possible at the end. So without further ado, Professor Coates, welcome.
Thank you, Harriet. Great pleasure, and welcome to everyone who's listening in or watching. I'd like to talk about heart failure with preserved ejection fraction, which is the Cinderella of cardiology because we've sort of ignored it as a problem. And as a result, I think we've given ourselves problems with knowing how to manage a really increasingly high proportion of our patients. So if I start off now with the first slide, and you'll see that this is the classical picture of heart failure. It's an interesting condition because it's simultaneously both one of the easiest conditions to diagnose and one of the most difficult to describe why it's present. So these are various manifestations of heart failure, from congested lungs to gross peripheral edema, central fluid pressure increase, and of course on the bottom left, a patient who's an outpatient but with exercise limitation. We can all recognize this as heart failure. But if we say, what is the aspect that tells us it's heart failure, we're often thinking, well, it's a sign of, at some stage in the past, congestion due to an abnormality in the heart. But it's very difficult to say exactly what that abnormality should be. So if I go to the next slide, you'll see that the European Society of Cardiology, in its most recent guidelines, has a very simple definition of heart failure, which is an abnormality of cardiac structural function, which leads to a failure to deliver oxygen commensurate with what the tissues require. More simply put, symptoms and signs resulting from abnormal cardiac structural function. Now you will notice there's no mention of the word impaired systolic function or a large heart. It's just assumed by many clinicians is what it means. It also covers the possibility of a small heart with impaired filling. When we look at the construct of diastolic heart failure, we can actually see it has a very long history. Nearly 100 years ago, in Physiological Reviews, Henderson described that the relaxation of the heart is just as important as the systolic contraction, and recognizing even at this early stage that it's a sign of aging, that as a man gets older, the heart relaxes more slowly, and that limits cardiac function and it limits the ability to exercise, thereby absolutely satisfying the criteria of a heart failure. When we look at the epidemiology of heart failure, and this is one of the largest surveys conducted in 2003, you see of 11,000 patients across Europe discharged from hospital with a formal final diagnosis of heart failure. And when you look at the ejection fraction, you'll see that it isn't clustered around low ejection fractions, which is what we normally think of, but for men, the most frequent ejection fraction was 30 to 35%, and quite large numbers up at very high ejection fractions. And for women, the most common ejection fraction in all patients in Europe discharged with heart failure was 60 to 64%. So clearly, high ejection fraction heart failure is not uncommon. It's not a rarity. Out there in the community, even in our hospitals, it's very common. And yet when you ask the heart failure experts or you look at the trials, these patients don't exist. They have been largely ignored when it comes to our clinical trials. And we really need to ask ourselves the question, why has this happened? And what is the impact of us ignoring these patients for so long in the clinical trials? There have been many population surveys, and the next slide shows the prevalence of heart failure in different community settings. Now you'll see that the prevalence varies depending on the diagnostic threshold, from 2 up to about 9%. But what is absolutely consistent is that a half or more of all patients in all these epidemiological surveys have what's described as preserved systolic function, and that's variously described as an ejection fraction above 40, 45 or 50%. Nowadays, we much prefer to use the term heart failure with preserved ejection fraction, or HF-PEF or HFpEF, as defining this entity rather than the prejudging term of diastolic heart failure. So now we think of HFpEF as a separate condition, usually now satisfied by all the signs and symptoms of heart failure, documentation of an impairment of cardiac structure and function, and an ejection fraction of the left ventricle greater than or equal to 50%. When we make this definition, it clearly illustrates a group of patients who are quite common in the community, much more common in the elderly, in whom treatment recommendations are really quite lacking. It does raise a question of what we do about those patients whose ejection fraction is between 35 and 45, a so-called intermediate group, and sometimes they're called heart failure with intermediate ejection fraction or mild systolic function, and most people think that they're probably more like heart failure with reduced ejection fraction, HFrEF, than they are like the quite separate group of HFpEF. If we turn now to the next slide, at the simplest end, we can just see that there are now two types of heart failure in clinical practice. On the top is a post-mortem specimen of a very enlarged, dilated heart. The echo, if it was live, you would see shows poor systolic function. That's the typical patient who might be on the heart transplant waiting list. Young, either a viral or a metabolic cardiomyopathy, or in some cases, multiple myocardial infarctions, poor systolic function, classically recognized heart failure. But the lower case, you see, of a very thick muscular heart, very small cavity. If you see the live echo, you'd see poor relaxation. That's just as much clinical heart failure, but a totally different cardiac pathophysiology. And that's the group that we really don't know much about how to treat. On the next slide, we can see temporal trends in survival in systolic heart failure. So that's heart failure with reduced ejection fraction. And this data comes from the Framingham study. What you can see is, you could say this is either a very good finding or a very poor finding. We have clearly improved over the last 2 decades, but not that much. If you look at 5-year survival of patients who get a diagnosis of systolic heart failure or HFrEF, you'll see that the 5-year survival rate is around about 40%. Over those 2 decades of major change, we've seen survival improve significantly, but it hasn't completely abolished the adverse outcome. You can clearly see that. But the yellow line is significantly better than the green line, significantly better than the blue line. So our treatments are definitely having an impact on all patients who present with HFrEF. If I turn now to the next slide, exactly the same epidemiological database, but looking at those with HFpEF, you can see that the overall 5-year survival rate is virtually the same as HFrEF. It's still 40%, and you can see that over this period there has been no improvement at all in survival. So we have failed these patients. They are about 50% or more of the heart failure patients in the community, and over decades of improvement, we have not shifted their 5-year survival 1 inch. And that really is a tragedy when it comes to the amount of effort we've put into devising treatments, and indeed what we can offer to a substantial proportion of our patients. Now, if we go under the surface and say, why is it that we haven't made that improvement? On this slide, you'll see I've listed the evidence-based therapies, separate treatments, both drugs and devices, that have been shown to reduce mortality and morbidity in heart failure in the presence of reduced ejection fraction. We have ACE inhibitors, we have beta blockers, mineralocorticoid antagonists, they're drugs like spironolactone and eplerenone, the angiotensin receptor blockers, ICD devices, cardiac resynchronization therapy or biventricular pacing. They've all passed the threshold. When it comes to preserved ejection fraction, this isn't waiting for the list to come down. There is no list. There are no treatments that have passed that threshold. Is it that these patients cannot be treated, or is it that we just haven't done the right trials, enough of them, and evaluated what could be done? And I think the answer is probably more the latter. Now when we turn to the guidelines again and look, what does the latest European Society of Guidelines say about the treatment of HFpEF, as opposed to the many pages of recommendations for how to use these effective treatments for HFpEF, we have only 2 recommendations: that if blood pressure is elevated, you treat it, and if they have atrial fibrillation or previous embolization, anticoagulators is recommended. And that's a tragedy that so far we cannot recommend any effective treatment for HFpEF. Of course, we do recognize these patients get congested, they get swollen ankles, they get short of breath, and these can respond to diuretics. But that's a symptom-based treatment. It's not a treatment given for its mortality and morbidity benefits. When we look at why this is happening and why this is an increasingly important problem, I'd like to go back now and look to see what happens with aging. We all know that, particularly in the developed world, but also in the developing world, the average age of the population is going up. People are living longer, birth rates are falling, and we're getting an older average age population. That has an impact on the diseases that present and healthcare resources. When we look now at tracking of left ventricular mass in the Framingham study, we see over the age range of 35 up to 75 in patients, these are individuals tracked with regular echoes, you see that left ventricular mass increases. So there is the development of left ventricular hypertrophy. In some, it may be related to hypertension, but in others, it's part of an aging process. As left ventricular mass goes up, diastolic function goes down. Systolic function may actually even apparently increase, because increased mass can give an apparently higher ejection fraction. But the increased mass leads to such diastolic impairment that you can get the symptoms of exercise intolerance that we classify as heart failure. When we look at the prevalence of the 2 types of heart failure, and we look particularly at preserved ejection fraction, on the right-hand side, you can look over this period of 1986 to 2002. The black triangles show the prevalence of number of admissions for heart failure with reduced ejection fraction is stable, or if anything, is very slightly reducing. But the prevalence or the number of admissions for heart failure with preserved ejection fraction is increasing, going up on a regular basis. And that leads to the left-hand panel, which shows the proportion of patients with heart failure who have a preserved ejection fraction is gone from about a third to now well over half over that decade and a half. So it is no longer an anomaly, it is actually the most common pattern of heart failure, but one that we have relatively under-recognized. That increase in age-related left ventricular mass is associated with impairments in diastolic function. And here we look at population-based estimates of left ventricular relaxation, top left, filling pressure, top right, and diastolic left ventricular stiffness in a very large number of patients. And you can see there's a highly significant correlation. As you are older, your left ventricular mass goes up and your diastolic function deteriorates. And that's almost an inevitable consequence of aging, possibly also related to deposition of fibrin and fibrosis in the heart. Now, when we start, and we did this a decade or 2 ago, talking in terms of diastolic heart failure, increased fibrosis, we think of a particular stiff heart condition, and it leads us into thinking of other conditions such as restrictive cardiomyopathies. And there are many different disease processes that can cause a pure diastolic dysfunction. You see it in fibrosis, the effects of aging, accelerated in hypertension and left ventricular hypertrophy, but also promoted by chronic low-grade ischemia. There are other rarer disorders such as infiltrative or storage disorders or endomyocardial disorders that can cause a similar clinical pattern, but they're relatively infrequent. The problem is this thinking has led us to look for specific treatments that improve diastolic function. And really we haven't come up with very many effective ways of doing this. And it led for decades of us trying to explore so-called lusotropic or diastolic enhancing treatments, rather than thinking that maybe the major determinants of heart failure outcome are the secondary effects rather than the pure cardiac dysfunction itself. And an example of this, and I'm not criticizing these authors at all because they've done excellent work, but very early on in 2007, there was a recommendations published by the ESC about how to diagnose diastolic heart failure, which is what it was called at that time. And if we flip to the next slide, we'll see a very complex algorithm of how to make a diagnosis. At that stage, it was called HFpEF, meaning heart failure with normal ejection fraction. That's exactly the same as heart failure with preserved ejection fraction. So it starts off with a clinical feature, symptoms or signs of heart failure. It then requires that they don't have HFrEF, so systolic function is normal with an ejection fraction about 50%. But then there's a highly complex algorithm that requires detailed echo measurements or left ventricular catheter measurements or a combination of echo blood flow, biomarkers including natriuretic peptides. And I can honestly say that I know of not a single clinician who ever used this in clinical practice. There was an interesting pathophysiological analysis of what do we mean by diastolic dysfunction, but in terms of clinical practice, it was meaningless because it was never followed. As a result, patients still remained relatively poorly diagnosed. No one was prepared to say that how many patients they had with diastolic heart failure. Indeed, recognizing it became enormously difficult. I felt sorry for family doctors who would refer a patient saying, I think this is heart failure, and they'd come to an echo lab or they'd see a registrar and be told this isn't heart failure, the ejection fraction's normal, missing the whole point that the epidemiological surveys have showed us that the majority of patients do have heart failure with preserved ejection fraction. It's just we have had enormous difficulty defining what the left ventricular abnormality is underlying the clinical symptom. So perhaps we should take a different approach. And the most recent ESC guidelines in diagnosing heart failure take a much simpler clinical approach. So when it comes to HFrEF, you only require three things. You need symptoms typical of heart failure. You need signs such as peripheral edema, raised JVP, cardiac enlargement, third heart sound, etc. And you need a low ejection fraction. Similarly for HFpEF, you need the same symptoms, similar signs, and the ejection fraction needs to be not reduced. But you need number four. You need something that tells us that something is wrong with the heart. But it could be hypertrophy, it could be left atrial enlargement, it could be any of the diastolic dysfunctions, but it could be other things. Some of these patients may have a dynamic left ventricular outflow tract obstruction, rather similar to a hypertrophic cardiomyopathy, that occurs only under stress. Some of them may get intermittent ischemia with impairment of systolic and diastolic function that's not there all the time. Other of them may be uncovered or precipitated by opportunistic arrhythmias. Now, when we go and say, why did we have no evidence-based treatments? Well, it could be that we've done no randomized trials. And I think that's an oversimplification. We have done some. On the left, I list the completed trials, and that's PEP-CHF, Charm Preserved, I Preserved, TOPCAT, and LVEF. I put two in brackets, which are the senior study that I was co-leader of, and the DID studies, in that they recruited heart failure irrespective of ejection fraction and had a subset with HFpEF. And there's one ongoing study, Beta Preserve. That looks impressive, but actually those 8 or 9 trials pale into insignificance when we've got hundreds of major trials in the HFrEF group. So it's not surprising, or perhaps we've been a little bit unlucky, but we've created our own bad luck by not really doing enough. If I now review the trials one by one, PEP-CHF was a trial of heart failure with preserved ejection fraction looking at the ACE inhibitor perindopril. The overall Kaplan-Meier survival curve is shown there. That's the chance of having an event which is a death or heart failure hospitalization. And you'll see there that the p-value isn't significant, p.545. The hazard ratio is 0.92, which means a point estimate is 8% protection, but as it's not significant, we cannot say that's proven. If you look in more detail, you see that early on at the 1-year point, the curves are separated. And if you analyze statistically at 1 year, it was a significant protection from death or heart failure or hospitalisation by perindopril. But of course, the trial was designed for 3 years. That wasn't the primary endpoint, therefore statistically it's not valid to say, let's look at that. The reason why that's important is over the whole trial period of 3 years, adherence to study medication dropped to 40%. In other words, at the end of the trial, more patients on active perindopril were not taking it than were taking it. And the placebo group, 36% of them, were actually taking active treatment. So at the end of the trial, the use of ACE inhibitors was virtually identical. So it's not surprising that we failed to see a difference because we weren't actually testing active drug versus no treatment at the end of the trial. That's just unfortunate, the trial design. It's very difficult to stop this happening, but this trial was more than any affected by that. Perhaps because physicians actually believed that these patients should be treated and they're unwilling to keep them on placebo. When we turn to another one, which is CHARM Preserve, you'll remember the CHARM program were 3 trials of candesartan in heart failure, but 3 different patient groups. One with patients intolerant of an ACE inhibitor, others on top of an ACE inhibitor, and the third program was for HFpEF, and that's the CHARM Preserve study. The primary outcome for this particular study was CV death or heart failure hospitalization. The Kaplan-Meier curve is shown there, and you'll see that the hazard ratio now was 0.86, which was a point estimate of a 14% protection. That's the adjusted hazard ratio. The overall primary analysis had a hazard ratio of 0.89 or 11%, but neither was significant. When adjusted for baseline prognostic markers, which is quite a common statistical technique, you can see the p-value was 0.051, which is agonizingly close to being significant, but it wasn't. So it's still classified as a negative trial, despite showing a trend towards protection by candesartan. Yet again, another negative trial, but still plausible or still consistent with a benefit, but just not as powerful in HFpEF and not definitively shown. The third trial was iPreserve, and this looked at the angiotensin receptor blocker irbesartan in a patient with elderly heart failure with preserved ejection fraction. There you see that the trial was yet again not positive. The hazard ratio was 0.95, non-significant trend to benefit, but the curves really overlap for 2 years. There's no difference. Only just after that is a very slight suggestion that irbesartan may be better. So these have been very disappointing trials. None showing any evidence of harm. Some got close to being significant, but none of them passed the threshold to get into positive recommendations in the guidelines. When we look at the ejection fractions that have been studied on the next slide, you see that the CHARM Preserve program went from 40 to above 60, the iPreserve went from 45, and of course CHARM had another study program with CHARM with low ejection fraction. So if we go to the next slide, we can analyze outcome based on left ventricular ejection fraction. And looking at the CHARM Preserve study, you can see at the top that those with an ejection fraction between 40 and 50% were close to showing a benefit. You see that the confidence intervals nearly up to the left of the line of unity, whereas above 50% there's no benefit. So people began to think maybe it's just that you need a low ejection fraction to get benefit, and that the closer you are to a low ejection fraction, the more benefit. And that's a plausible explanation, but I think other trials don't support that interpretation, as I'll show you. Now, Seniors was a different trial. That was the beta blocker Nebivolol, which is a vasodilating cardioselective beta blocker. And in this trial we recruited patients with both low and high ejection fraction. On the left, there's a little typo there. That should be ejection fraction less than 35%. That was 1,359 patients. You see that the reduction in the endpoint of all-cause mortality and hospitalization had a hazard ratio of 0.86, so a 14% protection, whereas those with a high ejection fraction, above 35%, had a 0.81 hazard ratio, so a 19% protection. Overall, this single trial was positive. when you look at the two components, those above and below 35%, there's no difference between them. If anything, the high ejection fraction patients is slightly better, but there weren't enough patients to have statistical power to prove it absolutely for each subgroup. So all we can say is Nebivolol reduces mortality or cardiovascular hospitalization in heart failure, irrespective of ejection fraction. There is no evidence the ejection fraction determines the response. The point estimate of HFpEF is better, but yet again we don't have the definitive proof we're looking for that treating HFpEF specifically is benefited, even though, if I believe clinically, this trial suggests that Nebivolol does work in that group. Now, we can look in more detail in the senior study, and if we look at quintiles, so that's dividing all patients by their ejection fraction, you see that the best response occurred in patients whose ejection fraction was between 32 and 35, or 35 and 45, so the borderline group. The highest ejection fraction group and the lowest didn't seem to benefit. Now, I think whenever you dividing trials into smaller and smaller patient groups, unless it's biologically plausible, you must look at these changes as if with some suspicion. And it's not biologically plausible that the best group have an intermediate ejection fraction, which is better than either high or low. And to prove the point, on the next slide, I divide the ejection fractions into deciles. So looking at the 10% of patients with the very lowest ejection fractions, the next, up to the very highest. And if you look at all 10 of those divisions, you see there is no biological trend whatsoever. The results as to whether you get a lot of benefit or not so much is totally random. And therefore, one can say with confidence that Nebivolol's effect on mortality and morbidity in heart failure is not determined at all by the ejection fraction. It works, and the ejection fraction does not determine how well it should work at all. Now, the most recent trial is TOPCAT, and this was looking at spironolactone, which you remember was so effective in HFrEF in the RAIL study. It didn't look at a conventional dose of spironolactone because to get some patent life that allowed some commercial investment, they looked at different doses. So the average dose was 30 milligrams rather than 25 or 50. But it was a large-scale, well-designed mortality morbidity study. And what it showed there, you see randomization of 1-to-1. It was powered to show a 20% reduction in the primary event, which is cardiovascular death or heart failure hospitalization, over a 3-year follow-up, assuming a primary outcome rate of 17%. The overall trial result is shown, and it's rather similar to the ones we've seen before, not quite significant. Spironolactone was trending to better. The hazard ratio was 0.89, showing a trend to an 11% protection, but the p-value was 0.138, so not significant. So technically, following the statistical book, this was a negative trial. When we look at the primary outcome there, the top line and the components, you see that none was significant, but there was a significant effect on hospitalization for heart failure, with 12% rate on spironolactone and a 14.2% rate on placebo that was just significant. But when the primary outcome isn't significant, normally you're not really allowed to delve down and look at secondary outcomes. So is this yet another failed study, or is it that we just haven't really powered these enough, we haven't selected our patients carefully enough, or we've just been unlucky? When you look at heart failure hospitalizations alone, you'll see there the curves separate early. It looks very much what we see in HFrEF. So if I put my clinical hat rather than my clinical trialist statistician's hat on, I'd say this is pretty good evidence that spironolactone is doing something useful in heart failure. But there are some very interesting features of the TOPCAT study that I think we should look at. The summary made by the trial investigators, and often this is dictated by the journal editors requiring it, which is conservative. Their conclusions were treatments with spironolactone did not alter the primary composite endpoint. Although reductions in heart failure were observed, we cannot say this is a recommended treatment, and of course it does require monitoring of potassium and creatinine levels that can be increased with spironolactone. On the next slide, I repeat the primary outcome, showing trend to benefit not quite significant, and remind you about the three components, with heart failure hospitalizations being significant. But then we start getting into secondary analyses to try and understand what's happening clinically and physiologically. On the next slide, the little pull-out box that has heart failure with preserved ejection fraction enrolled on the basis of two things. Patients could get into this trial either if they had demonstrated an elevation of natriuretic peptides, which you remember is a biomarker of heart failure, or because they'd had a prior heart failure hospitalization. When you look at the patients who had a biochemical test proving they have heart failure, then spironolactone was highly effective. It reduced the primary outcome from 23.6% to 15.9%, hazard ratio of 0.65, 35% protection, highly significant, P equals 0.003. Those patients who came in with only a prior clinical diagnosis without the biochemical proof had no benefit at all. Now, it may be these patients are different, or it may just be that the patients who got into the trials on the basis of heart failure hospitalization really didn't have heart failure. We all know in clinical practice that clinical diagnoses, if you're looking for patients to recruit, perhaps you get a little bit more flexible in what you interpret. It may be that at least within that group, there is a proportion of patients who probably had lung disease or obesity or some other cause rather than heart failure. That would explain why, if they became dominant, the whole trial becomes negative, even though there's a subset with true biochemically proven heart failure in which it's proven to be a highly effective treatment. When we look at the primary events based on baseline natriuretic peptide levels, you see in those who had a BNP above 100 picograms per mil or an NT-proBNP of greater than 360, they had a highly significant trend. That's at least as good as the effect we see with all beta blockers, and probably better than we see with ACE inhibitors in HFpEF studies. And I think that's the hidden message that we're not being allowed to see because it wasn't the overall trial design. I think we should move on and start doing the best for our patients and look at the biological evidence rather than just the standard clinical trial dogma. Before we get too carried away, Inder and Anand did a similar analysis in the I-PRESERVE study and actually showed a very interesting finding, which I cannot explain, that when you looked at NT-proBNP in that trial, the interaction was the opposite. In other words, the biggest benefit in I-PRESERVE was in patients with low natriuretic peptides, as opposed to TOPCAT, where the effect was only seen in those with elevated BNPs. So clearly we still have uncertainty in this area, but I think the era of not requiring natriuretic peptide confirmation of heart failure is probably over in clinical trials. I think we should be looking at NTP, natriuretic peptide elevation, as an essential inclusion criteria to make sure that we're not recruiting patients who don't have real heart failure at all. Now, my presentation so far suggests the only thing we have to offer is drugs, but that's not true. We know, because I did some of the early work, that exercise training is beneficial in heart failure with reduced ejection fraction, and people have begun looking at exercise training for HFpEF as well. And the exercise DHFP study showed an improvement in peak VO2 in training in HFpEF and a reduction in measures of impaired diastolic function. So training can improve important pathophysiology in HFpEF, and maybe that might be a treatment modality that can show that HFpEF can be improved, which previously we haven't been able to achieve. When we look in the future with our crystal ball gazing, we see that people are investigating other drugs. These are relatively small studies, but erythropoietin, udenafil, bosentan, the endothelin antagonist, and rizolazine are all being tested in small studies for a potential role in HFpEF, and people are devising devices so that CRT-type pacing devices and a couple of companies are now developing intraatrial septal devices that allow decompression of the elevated left atrial pressure to the right atrial in select patients as a potential treatment for HFpEF. To conclude, HFpEF is common, it has been ignored and is becoming more common and is no longer allowable for us to ignore this condition. It probably constituted multiple diseases, so although it's defined clinically as the signs and symptoms of heart failure due to impairment of cardiac function, there are multiple different types of cardiac dysfunction, so maybe the potential interventions can't be applied evenly to everyone. Maybe we need to pathophysiologically stratify our patients better. Some of the potential treatments address the neurohormonal syndrome of heart failure. That's like the beta blockers, ACE inhibitors, angiotensin receptor antagonists, mineralocorticoid receptor antagonists. Some address the pathophysiology of the myocardium. Perhaps we should look at pacing to change diastolic function. And some address hemodynamic abnormalities such as the intraatrial decompression devices. I think in the future we will devise treatments because we've come so close. At the moment, we're left with making clinical decisions without that absolute clinical trial power base behind us, but I think we can make some interpretations. So I'd like to stop there and just allow anyone who wants to ask any questions in that regard.
Thank you, Professor Coates. That was an excellent presentation with a fascinating insight into the trials and the lack of relevant trials in this area to date. We have had a few questions from the audience today, which I'd like to present to you now. The first one is all high ejection fraction heart failure diastolic heart failure?
I think the simple answer to that is no, it's not. Although we thought that if you don't have systolic function, you must have diastolic dysfunction, there's many more aspects to how the heart works that cannot be fit into either systolic or diastolic. So when I was in London a few years ago as head of cardiology at Royal Brompton, we were fascinated by a group of patients who absolutely fit the diagnosis of HFpEF, in that they would be admitted to the hospital with pulmonary congestion, they'd be short of breath, they'd be treated for heart failure. The next day or pre-discharge, they'd have an echo that showed normal systolic function and often pretty normal diastolic function. But I noticed one common finding, which was that some of the echo technicians, or if you looked at it, they said there was a little bit of basal septal hypertrophy. That's like a small increase in septal wall thickness up to 1.3, 1.4 centimeters, just under the aortic valve. It's so common that many people didn't bother reporting on it. But if you're a little old lady with a small heart and a small chest, an increase in that basal septal thickness can, under stress, when the catecholamines are high and the heart rate's high, actually cause an obstruction to the left ventricular outflow. So we took some of these patients who had been a diagnostic conundrum and did dobutamine stress echoes and some exercise stress echoes and showed that that little bit of basal septal hypertrophy caused an obstruction. They developed an outflow tract gradient, much more commonly associated with hypertrophic cardiomyopathy, and they all said that exactly reproduces my symptoms. That's when I go short of breath. So we documented that left ventricular outflow tract obstruction, rather than either systolic or diastolic abnormality, caused their symptoms, and when we treated these patients with beta blockers, their symptoms all improved. So it's just one example of a pathophysiology that is neither systolic nor diastolic, but because HFpEF is a diagnosis of exclusion, would fit the HFpEF classification more than the HFrEF.
Okay, I think that answers that really very nicely. So can I also ask you why there have been such a lack of trials?
That's an interesting question. If you look at the early trials, DIDGE was a very early study. The earliest heart failure study was the consensus in severe heart failure. I bet if you ask this audience or you ask any group of heart failure experts, what were the consensus 1 patients like? They'd say severe heart failure, 50% 6-month mortality, must have had low ejection fractions. Actually, they weren't. They included patients with both high and low ejection fractions. And they showed a significant benefit in enalapril. As we started doing more trials and the sponsors wanted to make sure that they got the results they wanted in an affordable trial, they went to the heart failure experts and said, tell us the people who've got the highest rates of events. I want to recruit people who have no comorbidities, but still are likely to have events, dying or heart failure hospitalization. And if you want to avoid comorbidities, you go for a younger population. If you go for a younger population, but you just don't want to have people who will stay through 5 years with no events, you go for very low ejection fractions. So it was an economic decision to start restricting future trials to low ejection fraction. And it worked. So once we had 1 or 2 trials that recruited relatively modest-sized studies, 2,000 patients, recruiting young people, so there was no issue of poor renal function, poor lung function, poor vascular function. So they had a pure patient subset. And the low ejection fraction dictated a reasonable event rate in which you could show something. Then everyone followed suit, and every drug company designed a trial restricting recruitment to patients with ejection fractions below 35%. That meant that all our effective treatments had only be proven in that group. So we caused these problems ourselves, rather than just recruiting all heart failure and then secondarily saying, let's look stratified randomization, pre-specified subgroup analysis to see whether ejection fraction mattered. We just said, we're only going to study this group. Now, 15, 20 years later, we have to play catch up and go back and try and find the other group because we excluded them for so long. In all the beta blocker studies, only one, the seniors, recruited patients with ejection fractions above 45%, and even then it was only a third of patients. So we have ignored them. We have caused the problem ourselves.
Well, let's just hope the future changes the situation. Professor Coates, we've had one last question, which is why didn't we study all heart failure irrespective of LVEF in our trials?
Yeah, that's the question. I think I probably covered that a little bit before.
Yeah.
I think it was an economic decision.
Yeah.
And I would hope now that if we're developing new treatments as we are, let's not make the same mistake. The senior study recruited ejection fractions across the board. It showed a positive effect, and it showed that ejection fraction didn't matter. Unfortunately, it wasn't quite big enough to prove it separately. I think for all new treatments we're devising, we should start off with a proviso that heart failure is a clinical diagnosis. All patients, irrespective of ejection fraction, have neurohormonal overactivity, and we should test that only if we see a significant interaction between ejection fraction and treatment outcome. Should we then say, okay, we can only recommend it for a certain ejection fraction rate? I think ejection fraction is an artificial construct. If you go back to the very early epidemiological data, there's a smooth distribution. There is no magic about 35%. A patient with 36 is not different to a patient with 34. I think we have caused the problem, and we should redo trials with the range of ejection fraction for all new treatments we're evaluating.
Okay, fascinating. Well, thanks so much, Professor Coates, for answering the questions you've had today. It's been a pleasure having you with us, and it just remains for me to say thank you on behalf of Radcliffe Cardiology and our viewers.
Great. Okay. Thank you very much. Are we finishing now? I noticed there's one more question that's just popped up.
Oh, okay. Yes, we have. Last-minute question. Let's have a read of that. What is the basis of diagnosis heart failure if ejection fraction and diastolic function are normal?
Well, I think in that case, it would be clearly based on clinical criteria, but you'd want confirmation of an elevated natriuretic peptide level. So either BNP or N-terminal BAP being elevated, that confirms you do need to document some left ventricular impairment, but it could be intermittent. It might only occur on exercise. It might occur only overnight. But you'd want to see elevated natriuretic peptides. I think that would give you enough confidence something is wrong with the heart.
Okay. Thank you so much, Andrew. So I repeat, thank you so much on behalf of Radcliffe Cardiology and our viewers. And we'll keep an eye on the future and see how things change in this area.
Okay, and thank you very much to the audience.
Super. Thank you, viewers, for watching today. And we'd be grateful if you could rate this webinar using the star rating system on your screens. So it just remains you to say goodbye, and thank you again all. Goodbye.
Great. All right, bye.
Bye-bye.